Hey folks, thanks for tuning in. So we're back at you with another interview, and this time we're coming at you from Nashville, Tennessee. Always great to be in this part of the country. So I'm also excited because I have a real special guest with me today. This is our first time meeting. I love it. Awesome. Yes. We did an interview last year. You can find that on the Ask the Expert playlist. But here I'm with my guest today in person. He is a doctor of physical therapy. He's also the founder and the president of Medical Minds in Motion. And it's my pleasure to introduce Rick Daigle.
I appreciate it, Carl. I'm excited to meet face to face for once.
Me too.
We've been connected on social networks for so long now, and we run in so many of the same circles. And
we do.
You know, we met last year with the video podcast, which was awesome. I had a blast with it. So
me too.
The fact that my wife Cassie and I and our son Keegan just moved to Nashville. We've been here for a month now, and I find out you're going to be here teaching a barefoot seminar in Nashville, in Franklin, Tennessee. So. Yep. It's awesome that we could get together.
Teaching one of Dr. Emily's courses in a couple of days here, so we're like 2 miles from where I'm teaching, so that's cool.
No, so I'm excited to get a chance to talk with you, and honored that you want to have you back in the podcast. So I guess the first one wasn't too bad.
It was great.
So
yeah, actually I've listened to it a few times.
Awesome.
And in fact, I was reviewing it earlier this week because I want to hear what were we talking about last year. I remember some of the things, and then that's a great interview. In fact, I'm going to put a link to that from here to that, so you can go back and refer to the first one we did. But today we have a little outline here. We have some things we want to cover, okay? And one thing, we were talking about this before we started the camera, mobility versus stability. Issues surrounding both of those areas. You were talking about some really cool stuff, and I was wondering if you could talk about that.
Yeah, absolutely. I mean, I think, being a physical therapist and being a movement professional, over my career, it's really progressed from, looking at one part of the body and looking here to really looking at the entire body as a system. I mean, we function in 3D. We don't function one joint at a time, one muscle at a time, one body part at a time. We function, a multi-systematic approach to movement. So when someone has a dysfunction that they can't do movement X, it doesn't always mean they're tight or they're restricted. So we get into the whole discussion of mobility versus stability, and we go into this fairly in depth in a lot of my seminars that I teach. When is a mobility issue a true mobility issue? And when is a mobility issue actually coming from a stability problem somewhere else? So the thing that I really drive home, and I have to credit, my experience in learning the selective functional movement assessment and learning from someone I consider a mentor of mine who actually is based out of Nashville, Tennessee, Mike Boyd. Okay, Mike is one of the creators of the SFMA.
Yeah, right.
And what I've learned from him and that foundation over the last 5, 6, 7 years was true mobility issues have to be consistent. They have to be. Someone has a lumbar fusion, someone has a cervical fusion where a surgeon goes in and they put some screws in a plate. No matter what position you put that person in, that segment's not going to move.
Right.
A patient develops a true frozen shoulder, true adhesive capsulitis. If they're in that frozen stage, no matter what position you put them in, they're going to have a mobility limitation.
Right.
But more often than not, mobility issues are actually being caused by a lack of stability somewhere else. The human body, in my opinion, and a lot of people agree with this, is if you can't move somewhere, it's going to take it from somewhere else. And I think it's one of our biggest strengths, but also one of our biggest weaknesses. Because at some point, the body's going to say, hey, idiot, something's wrong here, take care of it. And if you just go and you start stretching someone who has tight hamstrings because they can't touch their toes, how do you know they have tight hamstrings? So you look at it from 3 different aspects. You look at unilateral versus bilateral, you look at loaded versus unloaded, and then you look at active versus passive.
Right.
If you have dysfunction in all of those areas, you can now start to say it's most likely a mobility issue. Now I'm just scratching the surface, but let's say someone can't touch their toes and standing. Oh yeah, I feel the tightness and the pulling back of my hamstrings. Okay, great, but let's take a look at it a little bit further. That's loaded. So we get onto the ground in the unloaded position where they sit in the ground and all of a sudden now they can reach forward and touch their toes. You don't have tight hamstrings.
Right, that's interesting.
If you have tight hamstrings, you are going to have tight hamstrings in every position you put it. So then you would look at an active straight leg raise and a passive straight leg raise and, you know, compare their movement to what's normal. A normal active straight leg raise is roughly 70 degrees. A normal passive straight leg raise is roughly 80. So by looking at loaded, unloaded, unilateral, bilateral, and active versus passive, it gives you more information. And if it's inconsistent, now you have to go find, okay, why are they compensating? For me, I can't touch my toes in standing. I'll be the first to admit.
Ditto.
Yeah, that's boom on that one.
Yeah, totally.
But if I go into a long sitting position, I can lean forward easily and almost grab the under surface of my feet.
Oh, wow.
I've got a pelvic stability issue. A lot of people in the general public have a pelvic stability issue. Hamstrings attached to the ischial tuberosity. So their hamstrings being a big player, with a lack of pelvic stability, a lot of times those things will kick in and say, all right, I've got to do more work. Some sort of stability issue isn't there, so I'm going to fire more. So in standing, for me, my hamstrings are giving me some posterior stability to my pelvic girdle. I go into a long sitting position, the ground is now stabilized my pelvis. So the hamstrings can relax and say, oh, thank you. I don't have to do that work anymore, and you can lean forward. So well, that's just a very basic example and kind of just scratching the surface. The point is, you've got to look at more than one position to really know, is your client, patient, yourself, are you moving correctly?
Right.
Or are you compensating because of something else? Do you really have a mobility limitation, or is it the body compensating? So just because someone can't move doesn't mean they're tight. And I always use air quotes when I talk about tightness, because tightness is a neurologic response. Yes, someone has a knee surgery or shoulder surgery, maybe they develop some adaptive shortening of the tissue because they've been in a sling or a brace for 6, 8, whatever, how many weeks. But most tightness is a guarding response, it's a neurologic response. The body's creating stability somewhere else. So
I love that, that's really interesting.
And that can,
it's good stuff, man.
no, I appreciate that. And that could be, I don't care if you're a medical professional or if you're a movement professional or if you're, whether it's a strength coach or a trainer or whatnot. We're not talking about pain right now. We're talking about movement dysfunction. Obviously, when you get into talking about pain, that's when you go into the medical professional side of things. But we all work with movement. And if you can't move somewhere, you've got to figure out why they can't move in that way in order to properly progress them.
That's great. So we have a lot of trainers who watch this podcast series. And I know part of the classes, when I'm doing my short intro about myself, I'm teaching the barefoot classes. I share with them that when I first got into training, it was like we were talking before we started the camera. I just was thinking, people gonna want to tone up, bulk up, whatever, lose weight, burn fat. And I very quickly realized that although that may be their goal, they're not going to be doing it effectively. They may not do it at all if they're not moving well. You cannot train well if you're not moving well, which of course led me this whole exciting journey of now teaching about movement. But speaking of movement, that's a segue going into movement issues. And what I want to ask you is, what do you see as like one of the most common movement, or let's say mobility dysfunctions? What do you see?
I think that's a great question. Nice segue too, by the way. It goes so many different directions, and we can take that in so many different directions. And I've got to credit Dr. Perry for this next talking about the big 5 mobility dysfunction areas: upper cervical spine, the thoracic spine, hip, especially looking at hip internal rotation, hip extension, ankle dorsiflexion, and then like you and I were talking about before we started, again, taking this from Perry, great toe mojo.
Yeah,
I gotta throw that out for him. But the big toe is so important. If you can't push off, you can't move. Gait changes everything. But for me, I start with every single patient that I see. And listen, I'm not a proponent of cookbook therapy, cookbook rehab. I treat every person I see differently and specifically for what they need. But I look at one body part for every single person. You come in and see me because you've got a plantar fasciitis issue, I'm gonna go look at your T-spine. You come in because you have a shoulder problem, I'm gonna look at your T-spine. Our general population sit at a computer like this all day long.
True.
And what am I doing? I'm sitting in a thoracic
Yeah,
flexed position. The thoracic spine, to me, really is the foundation of where movement starts. You know, it's part of the core. It's that central piece. Everything kind of builds off of it. And unfortunately, a majority of our population has a lack of T-spine extension and a lack of T-spine rotation. And really, rotation, or the transverse plane, is where power comes from.
Totally.
But when looking at rotation, the transverse plane, and especially the thoracic spine, it's one thing to create the movement. You also need to be able to control it. You know, like when I'm teaching in my seminars, I always talk, you know, all right, I'm going to take a walk down the middle of the hallway. Is rotation happening? Absolutely. When you're walking, rotation's happening. But you're controlling rotation, preventing excessive momentum at the same time that you're creating rotation.
Right.
But really, you know, going back to your question of mobility dysfunctions, the T-spine is a major, major foundation, simply because, again, that lack of extension and lack of rotation. And if you can't extend and if you can't rotate the T-spine, you're not going to have proper scapular mobility. You're not going to be able to have proper force generation to the shoulder. Think about just breathing from a standpoint for a second. Now, my philosophy is, if you know you've been breathing for X number of years a certain way and you've developed that motor pattern, am I going to try in a 4-week therapy session to change the way you breathe? No, I'm not. But I want to see, can you at least isolate out your diaphragm? Can you at least generate different breathing strategies? But I can't ask someone to show me a good method of using their diaphragm to breathe a good belly breath if they can't move their T-spine. Because the diaphragm is a freak.
Right.
It attaches to over half your thoracic segments. You've got attachments to 2 or 3 lumbar segments. You know, there's a lot of research and a lot of different, people that believe that a piece of the central tendon comes down and intertwines with the hip flexor. I mean, that's just a freak right there. So if you can't move your T-spine, you can't breathe properly. Now, a good friend of mine, Rich Severin, who is a physical therapist, he's a cardiovascular, cardiopulmonary physical therapy specialist. And, you know, he and I, did a podcast about a year and a half ago where we talked about, looking at the ability to breathe, tidal volume, and just overall ventilatory capacity and how it relates to T-spine mobility. And there's tons of research that shows if you don't have T-spine mobility, you're going to have decreased ventilatory capacity. So you increase T-spine mobility, you're going to help someone be able to breathe better, which is kind of important. Breathing's kind of critical.
A little bit important, yeah.
But now taking it a step further, T-spine mobility, we look at sling systems, look at fascial planes. Something I see very, very commonly, not 100% of the time does this happen, but very frequently, I'll get in, I'll be doing some resistive isometrics, manual muscle tests, and I'll see someone's got a weak hip abduction test. Their glutes aren't firing properly. And it doesn't necessarily mean that they're weak. I'm gonna go up and take a look at their T-spine and start to address T-spine mobility issues. Because if you look at that fascial posterior sling system, right shoulder, lats, posterior shoulder, that comes across, those lats start to intertwine with the thoracolumbar fascia. Thoracolumbar fascia crosses over to that left side and intertwines with the glute fibers.
Right.
So a lot of times someone can't fire their glutes properly because they're not getting proper force translation. So you simply go in and you improve T-spine mobility, whether it's doing some simple just, kind of self-mobilizations on a foam roller, doing, active drills, doing active assisted drills, kind of focusing in different planes. Now all of a sudden, it allows force to translate better across that sling system. And sometimes it seems like magic, but it's not. You go back and you retest that hip abduction, and now they can hold you, they can resist you. You didn't do any glute strengthening exercises.
Right.
You just improved mobility so you've got better force translation.
Yeah, interesting.
And it starts with the T-spine. Now, does it work? Is that where everyone needs to start? Not everyone, because you've got plenty of people who have good T-spine mobility. But I need to at least rule that out as a problem or rule it in as a problem and then build from there.
Interesting. That just made me rethink a couple assessments that I do. So I'm going to work on that.
Nice.
Yeah. So I have, I do notice that with some of the people, that one I think it's called like open book, closed book.
Yep.
Okay, so I mean, some of these people could just go all the way back and they can just lay right down. Both shoulder blades are on the floor. While that knee is still on the floor on the other side. And then there are people like me who get to about 1 o'clock.
Yep.
And I'm done. The movement is over. Although now I'm at about maybe 2 o'clock. So it's increasing. But I'm gonna have to play with this and see, because that just gave me like this idea of some issues with a couple of clients I have that might be coming from other areas now.
Nice.
Because the thoracic seems to be fine. Our mobility is totally fine. Thank you.
You're welcome.
All right. Yes.
Making you work harder.
That's why I love this. I self-indulgently, I get to learn from experts, right? But I get to share it with all of you, so it's really cool. That's how I started doing this.
It's a win-win situation.
I'm totally going off on this. My whole reason for starting the podcast series was because I selfishly just wanted to learn everything I could. So
There's nothing wrong with that.
And I figured, well, I want to hang out with these gurus, but they don't know me from a bag of beans, right? Except I knew Brent Brookbush.
Mm-hmm.
It's like, dude, will you be like a guest for my first episode? Yeah. And then one led to another, and now I get to hang out with you, and I met Dr. Perry and Dr. Emily and all these people. So it's been really cool because it is definitely self-indulgent on my end, but you all get to benefit too. So
hey, there's nothing wrong with that at
I
all.
love this.
And just having these conversations, it makes me think too. And I love doing these things because you get talking, and yeah, you get to share your philosophy with your followers and whatnot. But I find whenever I teach, it gets me better the next time I see a patient that has these issues.
Totally.
So talking about it, now it makes me think a little bit, hey, I can look at it this way or look at it that way. So I think these are one of those things that just helps everyone involved.
It really is cool, because if I was to ask people just to hang out with me and talk to me and teach me stuff without something like a podcast, who's going to do that, right? But if I ask them to be a guest, then they say yes.
Absolutely.
It's really cool because then they also know they're sharing too. And actually, when it comes to teaching, what I really enjoy about the classes that I do for EBFA is I'll get you get physical therapists, massage therapists. I get trainers, I get all these people with all these different backgrounds. So I have something very specific and unique to teach them, right? But I get to learn from all of them too. So we have, as you know, you do this all the time. Teaching and that interaction gets me thinking. So it's like just endless learning always.
And you just said something that is very important to me, and I'm going to take like 30 seconds and I'm going to go off all my many soapboxes. Our professions, well, I'm on the medical side, you're on the non-medical side. Medical professionals come to my seminar, non-medical professionals come. Same thing for you. Our professions need to find a way to work together more. It doesn't have to be a headbutt. Yeah. It's like there's a lot of animosity between the two fields of physical therapy and chiropractic care. We should be working together. I am not a strength and conditioning expert. So, being able to work with you and learn from you and learn from others, I am not a chiropractor. Being able to work with chiropractors and learn from them, we can all help each other. And unfortunately, there are a lot of people out there that don't like to cross those lines, and they're missing out on such a huge opportunity to learn and make themselves better because we're all in it for the same reason, is to help people. I know it sounds cliche and whatnot, but really, we're trying to make people's lives better. So I love that you guys have different professionals that come to the EBFA seminars, because that's how we're all going to make each other better. And I think it's just, again, win-win situation.
I like that they come to those classes too. I was just listening to a Thomas Myers podcast again, that same one for about the 10th time.
Nothing wrong with that.
So loaded with information.
Now I gotta interrupt you for a second. I love Tom Myers, not only for his anatomy trained stuff, but he's a fellow Mainer like myself. So
that's right. He's in Maine.
Exactly. Gotta throw out that prop for Maine right
I got it. Yeah. Maine, beautiful state. So in this podcast, he's talking about the human movement, kinesthetic movement tree. And he talks about how, we're where we're at right now with all these different modalities, medical, non-medical, whatever. But his vision is that hopefully in 40, 50 years, we all do actually come together more so as one and realize that, well, it's like by default we start working together, you know, like you were just saying. I know that's a vision that he has that he'd like to see happen, and of course you would and I would too.
Absolutely.
I just get, you know, my own soapbox. I get really hung up on the people out there who just, you know, don't want to learn about all this stuff. That's like, you know, if we just talk about the subtalar joint alone, do you realize that if it's messed up, you're going to have some issues? Big toe. I mean, just one little thing can totally mess things up, set you up for injury and problems, and you know, so it's. I could go off on that for a long time.
Oh, absolutely.
But it's important to know these things. So.
Something I've learned is, you know, in teaching seminars for a while now, and kind of, you know, being out there on social networks and putting stuff out there, you can't make everyone happy. You want to try to, and you want to put your information out there, but the more you can expose to people, if you've got 50 people, if you shift that paradigm for one person, I consider that a success.
Yeah, that's true.
And it just builds and it grows and grows from there. So it's a battle I think we're not going to see end before we retire, but it's a good battle to fight.
It is. So, anything more you want to talk about regarding the T-spine?
Yeah, I could go for hours and hours on the T-spine.
That could be part two.
That could be part two. I think
so. We can set up our next interview right now. We're going to do part two of the T-spine soon.
Works for me. I think the biggest thing people need to look at is just make sure the person can do the movement before you start putting a load on them. Make sure if it is a mobility issue, have them work on mobility. If it's not a mobility issue, okay, then start to do some correctives and some stability type work. But if you put load, so if all of a sudden, I start doing, and let's say I don't have enough T-spine extension, and I start doing back squats, or I start doing, overhead presses with load, I'm now training the body to lock in that mobility issue. And it's going to take that much more to fix the mobility issue. So you nailed it on the head when we started, move better first, and then start to put load on that newfound movement. So I think that, to me, that's the big take-home point. Look at it from multiple planes, multiple angles. Never make an assumption. You know what happens when you make an assumption? It makes an ass out of you and me.
I heard you.
Yeah. It's just one of those things.
My mind thinking a million directions, but
just look at multiple planes, multiple directions, and then start to put the entire puzzle together and get back to basics.
Yeah, I like how you refer to life happening in 3D, because it does. I mean, that's something one of the master instructors with IASTM, who Ken Miller in California, San Francisco. You know Ken?
I don't know, but I know of him.
He actually teaches this workshop. He taught last year in Phoenix when we were out there for the Optimal Conference. Just talking about life happening in 3D,
Yeah.
And it's really important to keep that in mind. Another thing a lot of the trainers aren't really maybe aware of, and it's not to bash any trainers, it's not a judgment. It's that, when I got into it, I didn't know what 3D was when I first started training. So it's an evolution, and that's why we bring people like Rick to you so you can learn.
And if you want to go more into 3D, when you can finally get Adam Wolf on a podcast,
oh yeah,
Adam will go off the rocker on 3D movement. So
all right, yeah, I'm gonna find him.
Yes,
track him down.
Absolutely.
Okay, so we're gonna talk about CrossFit. Let's talk about CrossFit.
Absolutely.
CrossFit. I'll just come right out and just say it. I say this anytime in any interview that we talk about CrossFit, including an interview I did with Dr. Jeff Varghese and Sato Spengian. Awesome people. Sato owns a CrossFit box somewhere in New Jersey. And I even said to him, I said, CrossFit gets a bad rap. Injuries and this and that. We were talking a little bit off camera how you've treated some people who've gone to CrossFit, they've been injured and all that. However, it can be a good thing, and I was hoping you could share about your experience with it, because I know you're going to a place right now that you really like.
Yeah.
And what makes a good CrossFit box? I mean, I kind of know, but I want you to share with them.
Yeah, no, I think it's an awesome question. I'll kind of start with, anything in moderation can be a good thing. Anything in excess can be a bad thing. So anything in moderation. I think right off the bat, I agree with you. I think CrossFit has gotten a bad rap in a lot of areas. But what CrossFit has done, for starters, has gotten millions of people off their ass moving.
That's true.
And right then and there, I think that's fantastic.
Yeah.
I think that's absolutely fantastic. But like anything else, there are great physical therapists and there are crap physical therapists. There are great trainers, there are bad trainers. There are great lawyers and there are bad lawyers. I don't care what profession you're talking about. There are great CrossFit boxes and there are going to be not so great CrossFit boxes. And I think it's those few bad apples that make it difficult for everyone. So, like we were talking beforehand, I've treated so many CrossFit athletes. I've consulted with CrossFit boxes, but I had never actually embarked on the CrossFit journey myself. And I've come to the realization that I've not been where I want to be health-wise, fitness-wise, and have made that decision to make that shift and really put my money where my mouth is. And I've recently started embarking on the CrossFit journey myself. And the box that I go to here in Nashville, Whole Strength CrossFit, the owner is Ryan and Michelle Stemper. Absolutely fantastic. The first day Cassie and I walked in, they're FMS certified. They put their new athletes through an FMS screening.
Nice.
I mean, they start with the basics first and foremost, and I think that's what makes a good CrossFit box is they don't just say, do as much crap as you can and just load it. They say, this is where you are good, this is where we need to work, and we're gonna work on what your deficiencies are first. If you can't do a squat correctly, you're not gonna load it. We're gonna work on patterning, we're gonna work on mobility. We start every session with mobility work. It's not just jump in and do a bunch of burpees or do a bunch of thrusters with tons of weight. It's let's get back to basics first. And let's start from the ground level of where you're successful and then work your way up. It's kind of like something that Gray Cook says very frequently. Make an exercise challenging but not difficult. Find where someone is successful, find where they fail, and train them before the point of failure. So they start to groove that good pattern and then move from there. So I think what makes a good box is people that have a knowledge of movement and they understand limitations are going to vary from person to person to person, and making it a little bit more individualized. And these guys, we're lucky. We stumbled across it. It's just a couple miles from our house, so we originally went there because it was close. And we've developed a good friendship with Ryan and Michelle, and like I said, they do it the right way because they care about the individual that's coming in. So I think CrossFit has a great continued potential to be an excellent modality for people to get healthy and get moving. And it's a community. It's a lot of movements that are natural to people. I love deadlifting, not gonna lie. I love deadlifting, and it helps me because then I gotta pick up a 19-month-old off the ground.
Yeah, right.
Exactly.
It translates to daily function, right?
Exactly. So I think the places that take that understand how it relates to daily function is really what makes a good box. And we've had an awesome experience so far. And I think you're starting to see more and more and more of boxes like that. So like anything else, when something's new, you're gonna get a lot of good, you're gonna get a lot of bad.
Yeah.
But it's that upward trend that I'm seeing. So it's been awesome so far. I'm having fun. I'm hitting goals that I haven't hit in a long time. Just literally, last night, I know it's not gonna sound like much to a lot of people. I did 3 reps of a back squat at 175 pounds. I haven't been at that in such a long time. It's not where the max is going to be, but
it's great.
It's a start.
It's 175 pounds more than I'm doing.
So it's giving me goals and it's giving me stuff to shoot for, and really kind of making things come a little full circle for me. So it's been awesome.
Yeah, that's really cool. So just to clarify on that, because I want to make sure, just to clarify, I know with Saddle Suspension, who's an awesome guy and coach, and Jeff Hardees, right? So the two of them, we know we have people who know their stuff there. About movement, not to load if you're not supposed to load if you can't move right? So if you just sum it up in just a sentence or two, you find a good CrossFit box that includes coaches who basically understand movement, right?
Yeah, I think the way to sum it up is the good boxes out there, they understand movement, and they understand that every single person who walks in there that's new is going to have to start at a different point.
Yeah, good.
You and I walk into a CrossFit box together. There are going to be things that you can do much better than I can, and there are going to be things that I can do much better than you.
Yeah.
And they need to understand that they're going to have to train you a little bit differently than train me. And I think, just take the squat, for example. A great article was just put out, great blog by Brett Contreras. You know, the glute guy. And it was
the newest one, right?
Yeah, one of his newest ones. He's done it a few times and it's been out there, but it's how femur length affects squat mechanics.
I saw that one.
You and I are going to squat differently. I'm short. You're taller than me.
Yeah.
My wife Cassie, she's much taller than me. I'm going to squat differently than she's going to squat because of our body type. So I think the CrossFit box understands different body types, different people are going to move a little bit differently. There's nothing wrong with them moving differently, but it's getting back to the basics of what human movement should look like, making it challenging and not difficult, and making sure the quality is there before you put the quantity.
Awesome, yeah. I like that. That's a good summary of it all. So let's move into, I want to talk about your company, Medical Minds in Motion.
Cool.
It's what, 3 years now, right?
Yeah, just about 3 years now that we've been putting out seminars for PTs, OTs, athletic trainers, chiropractors. You know, most of our seminars are in towards the medical side of things. We do have some that that incorporate some movement stuff that are appropriate for trainers and whatnot. But our goal really is to try to shift the paradigm of continuing ed for for the medical world.
That's great, and I know you have an impressive list of instructors. Adam Wolf, there's a lot of great people on your roster. And so what's new with Medical Minds in Motion? Besides you moved to Nashville, now you're here.
Exactly.
And you have some stuff going on. We were talking about fascia.
Yeah.
And you can talk about whatever you want, but I want to make sure we hit the fascia because I think you've got some stuff going on there you're going to be teaching, right?
Yeah, well, first of all, from a fascial system, Adam Wolf has a course that is through us called Fascial Highway Systems. And it's all about 3D movement. And it's all about really how you've got dysfunction here, you might have dysfunction here as well too, because the body, while a muscle may be independent of each other, they're also dependent because of the fascial connections. I mean, you've got lines of fascial tissue, as obviously, they're going to go from the sole of the foot up the entire posterior chain and end up on the forehead. So being able to look at and not pigeonholing yourself into one body part or one thing, because we've got to look at the entire system. So that's one course. That's a 2-day seminar. Adam's going to be in Chicago, in his home area, in May, teaching that course. June, he's going to be down in Austin, Texas. July, he's going to be in Atlanta teaching that course. Getting into the end of the year, not end of the year, but kind of later in the summer and fall, he'll be in the Northeast and whatnot. But that's our big fascial course, and he takes a movement-based approach, and he's crazy. And he knows I'm going to say this. He's nuts, but I mean that in a good way. The way his brain works is just absolutely fantastic. But really, the new things that we're working on right now is we've developed a series of seminars on instrument-assisted soft tissue mobilization. So IASTM. Everyone, the big names that people hear that are out there, Graston and IASTM, they have their tools. They're fantastic tools. They have their own seminars. They're fantastic seminars. They teach their methods. What we've developed really is a best practice approach to instrument-assisted soft tissue mobilization. It's not specific to one set of tools or one specific tool. While, my preference of tools are, the Edge tool, which was created by Urson Religioso, and as well the Smart Tool Kit, Smart Tools Plus, created by Nick Colosi, who's a chiropractor out of the Cleveland area. I think from a one tool standpoint, my preference is the Edge tool. It's kind of like the Swiss Army knife of tools. It can do everything with one tool. And then the Smart Tool Kit is like the Rolls Royce of tools, but very, very cost effective on one standpoint. Just a high quality group of 5 tools that, you know, you can get any body part, any person, you know, treated.
Cool.
So, you know, we're developing that best practice approach, not specific to a tool. You can use the blunt end of a butter knife if you wanted to. You could use, you know, the back end of a reflex hammer if someone wanted to. But we've taken an approach of, you've got a mobility dysfunction, we're going to target the soft tissue and the nervous system with the tool work. We're going to use it to help correct soft tissue mobility dysfunction. Then now we're going to do a corrective exercise approach and start to get the person moving and get them into a loaded position with that newfound movement. And then finish it off with a standpoint of kinesiology taping, utilizing rock tape to tape across fascial lines to give proprioception, to help them start to be more aware of that new movement pattern we've developed. So it's taken a combination of tool work, movement, and then as well taping. So that's been really exciting. That's been a lot of fun. And one thing I do want to say, and I've done a couple blogs recently on the Medical Minds in Motion blog about instrument-assisted soft tissue mobilization, and I want to say this right now. You are not actively trying to bruise someone when you use the tools.
Okay.
That is a huge misconception. There's no company out there that teaches bruising that I know of. Graston does not teach bruising.
Okay.
You understand that, you know what, you might get a little bit of bruising as a response, but less is more.
But that's not the goal.
That is not the goal.
Yeah.
You know, you're looking for that erythemic response. You're looking for that nice redness. You know, a lot of the research behind instrument-assisted soft tissue mobilization is helping in that early acute phase of generating a good inflammatory response, generating the release of an enzyme that is supposedly meant to break up unwanted collagen fibers. There's still a debate as to whether that actually happens,
Right.
but a big aspect of it is the nervous system. The skin is an extension of the brain, and if now you start to rake so hard, the person's not going to be relaxed. They're going to guard. That's going to be a perceived threat. You know, it's kind of like you go to, you know, I'm just as guilty as the next person. Go get a massage and tell the person, yeah, just dig as hard as you can. If someone's digging as hard as they...
Some of the Ralphers go in.
Yeah, and there's nothing wrong with that. But, you know, my opinion is if you start digging on someone as hard as you can, they're guarding, they can't be relaxed.
Exactly, yeah.
The brain is perceiving that as a threat. So we take an approach of less is more with the tool work and use it as a combination to the rest of our treatments.
Yeah, so, I mean, it's just going way back to the basic NASL, CPS corrective exercise. I mean, that was what Brent teaches in the workshops. I mean, your body wants to guard itself against pain.
Yeah,
right?
absolutely.
So you don't want to be contracting the muscle that you're trying to actually release fascia on, especially. So let me ask you this, the same interview with Tom Myers I was listening to for the 10th time. Again, I tend to listen to these things when I run because it takes pain out of my running.
I like that.
Actually,
that's good.
I love running, but I had the worst run of the year the other day, and I just got so mad. I went like an extra 2 miles just because I was pissed. Like, it can't be this hard, so I just put on more podcasts.
Nice.
Okay, so that was a tangent, but anyways,
Sorry.
speaking of fascia release, instrument-assisted fascial release. So, do you have the intention of moving fluid around too? Because like Myers is talking about how there's fluid in fascia, and we can get some of that fluid out, and other fluid moves in. Is that anything you're thinking about when you're doing this?
You know, yes and no. I think there's a lot of, I'll be honest, there's a lot of controversy out there in the world of instrument-assisted soft tissue mobilization of what can it really do, what doesn't it do, and I think that gets into a much longer discussion of, okay, we know manual therapy works. We know that. Manual therapy works. Instrument-assisted soft tissue mobilization is a manual therapy technique. But do we really truly know why it works? It's so hard to really understand why it works. So yeah, when you're generating that erythemic response, you're generating a bit of kind of increase in temperature. That's going to obviously cause some vasodilation, which is going to help with fluid exchange. So yeah, it is there is some fluid exchange happening, but I think it's also very important to know that, you know, there's research out there that shows, and I forget the exact number, but something along the lines of like 2,000 newtons of force required to actually physically directly stretch fascia.
Really?
So if you were directly doing that, yeah, that'd be pretty aggressive. So the fascial release techniques really come from an indirect standpoint, from a nervous system response, from, addressing everything else around it that allows to have better force translation, that allows it to have better mobility. Now, it does happen, but it's a little bit more of a secondary response. But so yeah, you're getting some fluid exchange.
Mm-hmm.
How much, I don't think we really know. I think we know more from a manual therapy standpoint of soft tissue work, of what's coming from the nervous system. And again, that decreased guarding, that decreased threat. So you shut the brain down a little bit from a threatening standpoint, it's going to allow everything to start to open up and quote unquote release itself.
Interesting. Yeah, I was just curious about that. I didn't plan on asking you that question, but it got me thinking about what I had listened to with fluid, and then elasticity and the ability to tension it, but also to have elasticity in the fascia.
Absolutely.
Awesome.
I think one of the things to just kind of to mention about IASTM is it's like anything else. You find any research on it, the last line of every piece of research on it is going to say more research needs to be done and blah 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 blah. It's a relatively new technique. Yes, the original versions of it were based off of Chinese gua sha, but it was really in the 90s when the modern version of IASTM came out that was really based off of Cyriax's model of causing friction. And it's transitioned over the last 5-10 years to you're not gonna scrape really hard. You can do less and still get the kind of results that you want. So I think the research is getting there, but it's not where it needs to be yet. It's like anything else that we do.
So with the IASTM, is this something you're going to be teaching courses on?
Yeah.
Okay. So
yeah.
Just so they know too, I have a link on the screen, but Medical Minds in Motion is the name of the company. We'll put a link to your website there, and your courses are listed there,
Yep.
all the events and all that.
Yeah, courses are listed there. We have a couple versions of the course. We've got a one-day version, which is, the one day is just tool work. We tried to do all of it in one day, but it was just way too much. So the one day is just fundamentals of instrument-assisted soft tissue mobilization. The 2-day course is where we get into IASTM, movement, taping, and really just get in and play around and have a lot of fun. So I've got a couple instructors that work with me. Brad Papson, who's based out of Pennsylvania. Dave Doyle, who's based out of Connecticut. John Saylor is a new instructor of ours. He's a good friend of mine that I met out in North Idaho. He'll be doing some of the West Coast stuff. We've got our schedule up all the way through May. We're working on finishing up our June, July schedule. But I'm going to be teaching in Vegas at the beginning of April. I'll be teaching the course in May. I'll be in White Plains. I think that's the weekend of the 14th and 15th. The following weekend, the 21st and 22nd, I'll be in the Boston area. And then I'll be down in Florida in July, and I'll be in Southern California, I think also in June. So tons of locations. But like you said, if you go to our website, you can find it. People can also email me. You can put my email up as a link. It's just rick@medicalmindsinmotion.com.
I'll put that up there.
Yeah, super easy for people to get in touch with me. If they're in an area and instrument work is in their scope and they're interested in it, they can email me and say, hey, you've got a seminar coming this way anytime soon. We're always looking for host facilities too. So if anyone out there wants to host a seminar, on board with that. But everything off our website.
Cool. All right.
Yeah.
That's great.
We've also got the Medical Minds in Motion blog, which is
that's a great blog, by the way.
Oh, thanks. I appreciate that.
Yeah.
We use WordPress. I'll give you all the stuff so you can put it up. But a lot of social networking, a lot of blogs, website.
Yeah, and I'm not in the medical side of this, although there are times I really feel like I need to go to school and get into the medical side, because I want to crash these courses, come in, do it, learn that stuff, and be able to use it. Can't say if that's going to happen or not. Right now, I'm digging what I'm doing, but just learning this stuff and having getting some of the knowledge is so, it helps me with what I already do.
Yeah, and we have had some trainers that have come into some of our courses, and if someone wants to take one of our courses that maybe a portion of the course or part of it isn't necessarily in their scope, I think it's still good for them to kind of be able to observe. Now, if someone comes in and is not certified in any soft tissue, technique, they're not going to be able to grab the tools and start raking at someone.
Sure.
But being there and learning and seeing and observing, we've had plenty of people. And then when we get into the correctives and whatnot, the movement-based stuff, as long as they're not using it for treating pain, then it's appropriate. So we try to make our stuff appropriate for as many people as possible, but understand where that line of scope.
So I might be in White Plains in mid-May.
Hey, you are more than welcome.
I'd
to
love
be
to
a
do
blast.
some of that. I would love that. Oh, this is cool, man. This has been awesome.
This was fun.
Thank you. I really appreciate
This was definitely fun. Absolutely.
Great to meet in person, great to talk, and my brain is like, every time we talk, it's like, I just got all this stuff to think about now, which I'm sure you do too. So, links are on the screen throughout the video. We'll have that up there, medicalmindsinmotion.com.
Yep.
Okay. And thank you so much. Rick.
No, awesome. I appreciate it again too. It's been a lot of fun, and like you said, great to meet face to face and
Oh, it is.
not be social networking friends anymore.
Real friends.
Exactly. Absolutely.
Yeah. We have another interview. I'll have that on the screen too from online thing we did last year.
Mm-hmm.
But in person, you have the whole energy thing too. Like Rick has awesome energy, and I feed
you
off of
too.
energy.
You do too, so it's
I
great.
totally feed off of that, so it's really awesome. So I hope you enjoyed it. I know I had a blast, and I've got some. I'm going to watch this now, over and over, so I can learn more stuff. But thanks again.
Awesome.
All right.
No, thank you.
Thanks so much for watching. We'll be back at you more soon with more interviews. Have a great day.